Maintenant, nous allons donner la parole au docteur C MVONDO qui va nous donner, parler de l'expérience de la chirurgie pédiatrique cardiaque. 16 ans d'expérience de chirurgie cardiaque pédiatrique en Afrique subsaharienne. Vous avez la parole.
I will go back, start again in English. So this is a presentation we try to do today to share with you what have we done so far in Chisson with regard to heart surgery in children. As sisters just explained to us, the cardiac center was built toward 3 objectives, and the most important was to set up an autonomous cardiovascular department, which was done. You can see some of the image of our buildings. And as the director said, we had some challenges over the past 3 to 4 years, and the cardiac center, even though the main basement is still in Chichon, we have expanded our department toward the country. And the road of autonomy was based mainly on 3 aspects. The first was to train local people, increase the number of regular admissions from experienced centers, try to recruit part of the Cameroonian-born specialists, and to create, as sister just present to us, a social office to increase the number of patients who will benefit of surgery. This is what have been done so far, the number of surgical missions or collaborations, the number of people trained locally. And the surgical activity to date, you can see how we succeed to reach, even though this was not our main objective. We're expecting to do more than that, but we are not far from doing 1,000 surgeries. And since 2019, we had to reorganize our outreach mission. This is why we had some drop in the numbers. And the autonomy of local staff may be helped by the COVID-19 pandemic and the social crisis, has seen how the autonomy of the local team has grown up to 100%. Now we are able to perform by our own, the majority of cases in our institution, with even an improvement with regard to the operative mortality. So we are treating children most of the time, and these children mostly have congenital or rheumatic heart disease. African continent is a continent where you have a high growth rate, of course, if you have to compare with the Europe. And then, of course, we have a high number of children born with congenital disease. This is the number per million you can find in the sub-Saharan Africa, which is quite higher when compared to the other regions. So if we have to extrapolate some numbers, we can maybe think that more than 6,900 children are born every year with congenital heart disease. This is a study by our colleague, Dr. Tanshu, some years ago, reporting the percentage of patients admitted at the cardiologic department. 3% of those patients had congenital heart disease. What happened is that in a higher income country, the mortality over the past years have clearly reduced. But you can see in low income countries, there has been really not great improvement with that this regard. And the profile of patients with congenital heart disease in our region is almost the same we found for rheumatic disease. They used to come late or because access to specialized services are low. They are coming where the conditions are, of course, bad. They used to be in malnutrition status, and of course, they are poor people. So the surgeries we have done so far, you can see number around 360. We operate, let's say, from 5 months to more. The mean age is around 5 plus 3 years. These are the main diseases that we encounter, always from the study of our colleague, Dr. Janju, some years ago. Okay, so the main surgical procedures we are doing in the field of congenital heart disease are ventricular septal defect, tetralogy of Fallot, patent ductus arteriosus, atrial septal defect surgeries. This is some of the results in terms of hospital mortality, is to take into account even the dynamic we had from the beginning with the learning curve, because a lot of the death that occur in cardiac center was in the beginning of the project. So the second disease, which I have already presented, is rheumatic disease. And of course, we take some amount of patients below the age of 18. The majority of these pediatric patients, of course, were having rheumatic heart disease. This is a study on your right, a table that we had from a study on mechanical valve replacement we published 2 years ago. The use of mechanical valve and all the data related to the operative mortality. We try to compare also this doing valve surgery in a younger population with what may be the result in the European countries. The result, even though the populations are different, so we could not really compare the two populations, but from our side, the results are not that bad. This is what happened, even though the slide was supposed to be in another position, but for sure our hospital mortality has not increased despite the fact that the local team was in charge of the majority of the surgeries. This is the result of the two groups. So the challenges we are having, we have discussed again and again. The patients are coming very late, and of course we are seeing them in very bad conditions. We do think also that it's important to take care of the whole spectrum of congenital heart disease, for instance, to include or to involve other specialties, not only cardiologists and cardiac surgeons, but also neonatologists, gynecologists, in order to be able to operate children with complex disease like transposition of the great arteries, anomalies, venous return, and so on. So our 13 years experience treating children is quite acceptable. There's still a lot to do. We do need, of course, to have a more multidisciplinary approach to treat these patients. And we have to push on and continue to develop a local network in order to treat the majority of patients, especially those who are coming from underprivileged environment. Thank you.
Merci, Dr. MVONDO.